Good afternoon, everyone. My name is Rachel Summer, and I'm pleased to welcome you on behalf of the Center for Health Affairs to today's session of the Northeast Ohio Opioid Education Series. We really appreciate you joining us as we continue to foster conversations around improving care and reducing harm related to opioid use. Today's session, Leveraging Health IT to Support Opioid Use Disorder Care, features two experts who have joined us here today, working at the intersection of technology, clinical care, and systems transformation. So we're really honored to welcome Dr. Sean Kelly, who is the Chief Medical Officer and Senior Vice President of the Customer Strategy for Healthcare at Imprivata. Dr. Kelly is also an emergency physician at Beth Israel Lahey Health and Assistant Professor of Emergency Medicine at Harvard Medical School. He also, in addition to all those things, serves as the co-chair of the Clinical Advisory Subcommittee for the CHIME Opioid Task Force, which offers national thought leadership on leveraging technology to combat the opioid crisis. In addition, we are also pleased to welcome Dr. Jonathan Siff, Professor of Emergency Medicine at Metro Health System here in Cleveland and Case Western Reserve University. He's Metro Health's Chief Medical Informatics Officer and a faculty member with the Center for Clinical Informatics Research and Education. Dr. Siff is board certified in both emergency medicine and clinical informatics with a focus on substance use disorder, emergency department operations, and provider experience. So we're very grateful for their time and being with us today, sharing their knowledge. But before we begin, I just want to do a few quick reminders. Today's session is being recorded, and it will be shared with all of you after the session and put onto our YouTube channel. So if you want to share it with any of your colleagues or those who maybe couldn't make it today, we encourage you to share that. And you're welcome to post questions in the chat anytime. There is the Q&A function, but that does not show your questions to everyone. So if you want to put it into the chat, that's great too. We'll be monitoring that. And without further ado, I want to welcome Drs. Kelly and Siff to today's presentation.
Thank you so much, Rachel, and hi, Jody, and everyone else on the group. Very pleased to be here today. As mentioned, my name's Sean. Happen to have chaired up the clinical subcommittee on the opioid task force for CHIME for a number of years. And I'm glad to have John, Dr. Siff, join me as well, especially since he's in your area at Metro Health and has done a lot of wonderful work to help fight the opioid crisis. And as mentioned by Rachel, our main purpose has been to fight the opioid epidemic, of course, but that's really using and leveraging the power of IT and informatics. And so obviously there are a lot of different entities out there trying to work together to fight the opioid epidemic, and a lot of great work happening in the face of a daunting epidemic. And our notion was, and I see both Patty and Ed on, two of the co-founders of the committee, and so I'd like them to say hi in just a minute too. But we've been led by them really, close to 8 years now, doing work where our biggest focus was trying to bring to bear the power of informatics and the work that's being done throughout informatics, and focusing on pragmatic and realistic things that can be done every day now, and of course improving through the future. But the idea being, are there practical things that we can do and help each other with to share best practices and lessons learned? And so, I guess that is one central theme is, pairing IT experts with operational and clinical experts, and the added synergy there and the force multiplier effect of that, I think it can be very powerful. And so I think that, the goal of today, we have a few slides, like 3 slides, I think, but in general, we'd love to make this interactive and try to be as helpful as we can, and maybe hopefully make you aware of some resources that you could leverage. And so we'd love for you to have any of your questions answered. And, to open things up, I'd love to just ask everyone, what are you hoping to get out of the webinar today? Is there anything specifically you'd like us to talk about? And, we're happy to, if you want to put that in the chat, or if you'd like to just ask us, we'd love to make this as interactive as possible. While you're thinking about that, maybe I'll just have Ed introduce himself, and then Patty, because we just have a couple other people here who have been instrumental in leading the opioid task force. And then Ed, I will talk a little bit more about CHIME in general, but please let me know your perspective as one of the founders.
Well, thank you very much. I'm honored to be here, and also having helped start the CHIME Opioid Task Force in 2018. One of the first things we did was publish a playbook for hospitals on doing better stewardship around opioids and how IT can play into that. And what you're going to hear today is our version 2 of that playbook, that after 6 or 7 years, we saw a lot of change in the industry and a lot of advancement in EMR capability in that, and also the recognition of the need for better interoperability, not only for substance use disorders, but all behavioral mental health issues. So I'm really honored to be here. Thank you for having me. I'm looking forward to the discussion today. So thank you.
And Patty?
Sean, you went on mute. Okay, go ahead.
Hi, everyone. I'm Patty Lavely, and I have been a part of the Opioid Task Force since its inception. And I guess for the last 6 years, maybe, co-chaired with Ed. And first of all, thank you so much for having our committee represented here. And you've got 2 of our incredible experts that are going to talk about some of the work that we've done. For me, it's always good to hear them, because we all come to this work, or at least our committee, because we have a personal connection to the opioid crisis, usually not in a good way, right? And so to continually be able to interact with professionals that can make a difference, that care, is pretty amazing, and probably one of the highlights of my 30-some year career. So, and you'll hear that from the folks today for sure. But we have done a lot of great work. Our playbook is one of the very tangible deliverables, but we also have a lot of great webinars and podcasts, and with not only Doctors Kelly and Sip, but some of our other clinical advisory, as well as our IT experts. And I see a couple of them on here today. And I think we've done a great job of sort of marrying the clinical and the technology, and always having to sort of position ourselves to be, on that line, because it's easy to go one way or the other. But I think we've done a really good job sort of taking the best of the technology, saying, how can we make the clinical better with the technology? So anyway, great to be here. Thank you.
Great. And so just a little bit about CHIME in general. CHIME, or the College of Healthcare Informatics Management Executives, is really one of the premier associations across the industry, full of healthcare informatics experts and managers and leaders. And so a subset of that is the CHIME Opioid Task Force, which was founded back in 2018. And one of the subcommittees is the Clinical Advisory Committee, of which John and I are a part, and then there are a number of other people on this call as well that were parts of the other committees, as Patty said, including education and also partnerships and IT and innovation. And as mentioned, the whole idea was, the premise in the beginning was, look, this is a rapidly worsening epidemic. At the time, a lot of it was iatrogenic. It was caused by us, right? We were overprescribing. There weren't best practices. And when you went and looked through things like your own order sets at a hospital, we were often horrified to realize we were sending people out the door, right, John? In the ER, maybe not so much, but we'd see coming out from the hospital, someone would go in for a minor surgery, wisdom tooth, or something else, and they'd go out with a bottle of 60 Percocets on a standing dose. And that person was either taking them and potentially becoming addicted and struggling with that, or a teenager in the house was finding those pill bottles and wandering off and using them. And so a lot of us were sitting around and realized that we had the ability to potentially go in and standardize and change those things. And so Dave Lair, who is one of the founders as well, I had a great comment. He was like, man, what if I had a handbook for myself 6 months ago when I was embarking on this journey on how can I make a difference? And we don't want everyone out there reinventing the wheel and having to do the same thing. And, maybe they discover the right way and maybe they don't, but we have a powerful community that actually builds these order sets and builds the default rules. And therefore, that's a powerful mechanism. And so that became sort of like the impetus and the marching orders. And a lot of that we decided on the spot was like, hey, we're gonna create a mission statement, and you see it here, to really try to turn the tide and have a positive effect on the opioid epidemic. But our real mission was to use the knowledge and expertise of the nation's healthcare IT leaders, and then to disseminate that and then make those tools available to the operators and the clinical experts. I don't know, John, if you have anything that you want to add to that as we move forward.
Well, I think we talked about this yesterday, Sean, when we spoke. Early on, pretty much our focus was on, how do we turn off that spigot? How do we not have defaults for 120 Vicodins after minor surgery? And trying to push out best practices, push out innovations, because honestly, especially early on, the vendors really weren't aware of this. They weren't building things into their model systems. So it was up to every individual health system to figure this out. And that, of course, does not make any sense. So, I think the original guidebook was a really big step forward in showing the power of a group like this that can push out best practices to individual health systems and really start to make a dent in this. And we did. We moved from phase 1 of the opioid epidemic, unfortunately, into other phases, but, really made a huge dent in the piece that was iatrogenic.
Yeah, let's talk about that. Maybe, Rachel, if you don't mind going to the next slide, that would be great. Take us back a little bit to, when we initially started with this, we realized that, sorry, this is
It's not
different than what we had, but anyhow, so maybe try the next slide. I think that might have the playbook on it. Thanks, Rachel.
There you go.
Yeah, here we go. We were all sitting there realizing that some of us had started to do this in our own institutions. And to Jonathan's point, much of the problem at the time was overprescribing and faulty order sets. So, we kind of went through a step-by-step guide to how to actually make a difference and systematize this in a way that makes sense. And so the first thing that many places need to do is actually establish some sort of a stewardship committee. And so, that in itself can be, not always intuitive. And so we created that guideline and then realized that very quickly you have to know the data and understand the facts in order to act on it. And so creating a dashboard of understanding, like, well, wait, how many morphine equivalents are being prescribed and who's prescribing them and how are they being prescribed? And isn't the ER a little different than outpatient psychiatry, which is a little different than the ICU, which is a little different than palliative care, which is a little different than pediatrics? And then as we moved along, realized that, hey, anytime you can automate any of that and get data feeds instead of trying to ask people manually to go find it, you're going to increase the ability and the usefulness of all of that incredibly. And then focusing on what's really important, there's a ton of data out there, but there may be a few data points that are actually more important than others. And again, that's all in these chapters, and we can move over and I can show you where that link is, and we have it in the slides that we'll share with you. You can go to the Opioid Action Center and go to any of these chapters, and it will give you a blow-by-blow, an introduction and background, and then it'll walk you through how to establish something like this. And then we usually will have 1 or 2 case studies with pictures and examples saying, hey, here's an example, a template that this hospital system used, and here's the effect it had and the positive impact. just walking through the rest of these chapters, because I think it's good to remember that some of these things, while they might seem basic, are absolutely important. And John and I are both ER doctors, so we know, like in our world, you can sometimes get caught up in the minutia, but if you're not dealing with the most important, life-threatening, and most foundational things, then bad things can happen. So for us, the instinct is look, airway, breathing, circulation before you move on to some of the rest of the things. And so to me, the basics, I never want to lose sight of the basics. And so, actually creating a committee, creating a dashboard, and then, managing the actual change, right? I mean, there are human beings involved here. So actually understanding how you do education and change management and incorporating feedback in the human side of things is actually as important sometimes as the data side of things. And then one of the most powerful things, as we talked about, is just understanding what order sets and all the defaults that are out there. And just changing that can be incredibly powerful. And I think we all experience this. And the catchphrase that we sometimes like to use is to make the right thing to do actually the easy thing to do. And human beings will do that 9 times out of 10. If you give them a pathway that is evidence-based, proven, safe, and effective, generally they follow it if it's harder to go and get around it. But if you make the safe thing to do really hard, what do we all do, right? We just can't, we naturally don't do that. It's not in human nature. So there's a real science and an art to this. And simply walking through and making sure that a lot of the care pathways and the order sets that are out there, any of the defaults are set in a proper way. I mean, just that one example of the Percocets being prescribed, oxycodone being prescribed after surgery, or incorporating a lot of non-opioid methods for pain control and for managing patients. And that, of course, can be adapted to the different specialty, and it can be adapted to different patient populations and locations. But even just starting with the basics, where you switch things to PRN as needed instead of set dosing, and making sure that before you get to prescribing those things, you actually talk with patients and explain to them and have information saying, look, you just had surgery, or you have a known injury and it's expected to cause pain, and here's what that means. It's actually okay to have pain. If, here's how you can deal with it. And here are some medicines for breakthrough pain if needed, but here's some warning signs about those medicines, right? They will make you constipated. They are addictive. You have to be careful because they make you altered. And, there's a way to automate all those things and to make sure that, for example, they go out in the patient's chosen language, and that there's, a question and answer period where they understand things. And, there's a lot of nuances to these, but again, there are a lot of places who have kind of been through this before, and now we've captured as much of that as we can to try to immortalize it and make sure it makes sense for people. I'll pause there. See, I don't know, Jonathan or Ed or Patty or anyone, if you have anything to add to that.
Well, I would just add that certainly with respect to the order sets and trying to guide providers to do the right thing and make it easy for them, one of the things that I thought was most important early on was that there was actually some good research done about how many pills do you really need after a hernia surgery? How many pills do you really need after a C-section? And that allowed us to create tools with some scientific backing rather than just, this is kind of what I think. And I think that was important in helping to convince providers to change. Doctors don't like change. They really don't.
Doctors don't like change. And then the other thing they don't like is a bad report card. So I think the other fun thing to talk about is that dashboard. And everybody thinks they're an exception. Everybody thinks there's patients are sicker than others, and everybody thinks they only prescribe this amount. When you show actual data, and it's real, it's evidence-based, it does change behavior. And sometimes it's not until you see your own data that you realize, oh, wow, like actually, I'm a little bit off the norm here and I could improve. And so there's no better way to fix a problem. You start by shining a light on the problem. Ed.
Well, thank you. You guys are doing a great job. I just wanted to add, and a little bit addressing one of the questions in the chat. CHIME was founded and I get to be old enough to say I was a founding member and a chair in our 6th year, but we founded CHIME to share best practices and partner with our vendors better because at the time there wasn't good partnership. And so it really an education and sharing leading practices and errors and mistakes made was part of our core. And so you're going to see that on this task force throughout it. We leveraged those two principles. And in fact, all the main EHR vendors are on our task force, are as active members as well. And so in terms of the question in the chat, it, basically it's about sharing your experience and creating a transparent learning experience to say, hey, this works, this doesn't. Here's what we did about this problem. And the whole concept of the playbook was this was our best advice in 2019 of how hospitals should do this and et cetera. So I think that's the concept of it is that we're not trying to hide mistakes, we're trying to expose them. And mistakes are probably a wrong word, but we wanted to move the needle on not only prescribing opioids, but also the stigma associated with substance use disorder and opioid use disorder now. That is still embedded in our medical professions and our society that these are just bad choices. And I know firsthand that's not the case. And so does everyone else on the task force. So, somebody comes in the ED with an overdose, that person has a chronic illness. They haven't just made bad decisions, and they're going to need long-term care, not just an acute intervention. And so that's what it's all about, is exposing the truth, talking about it in a different way, talking about the realities of addiction and what it leads to, et cetera, and how we can do a better job. I think going downstream, and I'll shut up, Sean, it's your show and Jonathan's, but I really think we're on the cusp of having a lot of data that we can use to now look back and say, what should we have done? What could we do better? How can we predict who's going to develop substance use disorders? What are the characteristics? We all know that readmissions are a sign of we discharged the patient too early. But what about repeat visits to the ED, et cetera, et cetera? So I think we're onto something here. And as you know, the hospital side has adopted EMRs probably a 98, 99% level over the last 10 years. We're now seeing the gaps in the community side where a lot of behavioral health is delivered. So anyway, I'll stop there and hopefully that was helpful.
So I don't know, Sean, everything that I hear from Ed makes me think of things because he's got so much background in this and understands this better than any of us could, the history. But one of the things you said, Ed, was transparency. I think that's really important. Sean was talking about the dashboards. There was a lot of resistance in our organization to sharing that data. People always think they're different, but they don't want anyone to know. And it took time for us to convince, leadership that we needed to share this data because you're right. No doctor likes to be at the bottom of a list or on the bad list. So that does change behavior, but it's hard to get people to accept that transparency.
Addressing, that question in the chat around, recommendations to foster collaboration. I would agree with Ed and Jonathan that we have seen no resistance in collaborating, particularly for this patient population. This is a high-risk population, very difficult to take care of with a lot of morbidity and mortality and a lot of implications when you don't know the whole story of someone's coming in. And so I would say in many ways it's the opposite. In fact, we used to have kind of like shadow systems off in the background. We had a box that we knew when people were shopping around to different ERs. We sort of kept track of that we'd even call our friends at another hospital, or if we moonlight at other hospitals, we try to do these workarounds. And so I think the idea of collaboration across hospitals, and you see this now, the trend is, HIEs and Care Everywhere, Care Anywhere, and all the rest. A lot of hospitals, even competing hospitals literally across the street from each other, and we experience this in Boston, are perfectly willing, in fact, encouraging, trying to share data and information, not just for public health, but for active daily care. And so I actually feel like in this particular population, there's not as much resistance as there is willingness. The problem comes in interoperability, particularly between, not just between hospitals, but when you go to the community and behavioral health, because of stigma and other issues there as well, and then fragmentation of the electronic records and other systems used in the community, and smaller that you go out compared to the bigger mothership hospitals. And that's that second question, or first question in the chat, which I'd actually wait until we get to the second playbook, because that's where we've started to delve into that more. And then just before we go on, I want to address the other question in the chat just around insurance companies and PBMs, which is a great idea to set limits or controls on opioid prescriptions. I don't know if that's trending in the right direction, honestly. I don't know if Patty or Ed or Jonathan or Josh or anyone on the line knows that. Does anyone know whether there are limits from payers? I can talk through some of the EPCS ramifications of Medicare Part B reimbursement and things and state regs, but I can't talk to PBMs or payers. Do you know Ed or Patty or anyone or Jonathan?
We've seen some of our payers become progressively more aggressive in sending notifications to providers. You prescribed this for your patient. Are you aware?
Mm-hmm.
And here's their list of other things. The challenge again goes back to interoperability, because that insurer is only going to know what they paid for. They don't know if a patient got a prescription in another place and paid cash for it. And one of the big interoperability pain points to me isn't so much between the EHRs, it's with the pharmacies.
Yeah.
And how I know, like Kroger, I think in Southern Ohio doesn't participate in information exchange with other organizations, which makes it really hard.
We could talk about that a little bit, because I think both the next two chapters, EPCS, electronic prescribing of controlled substances, and PDMPs, or prescription drug monitoring programs, address that issue where we look back in the day, this was almost impossible to deal with, and now luckily we made a lot of progress on these things. So first, EPCS. Many of you might be aware, but electronic prescribing controlled substances, or the DEA enforced rules that, all opioids or other controlled substances, Schedule 2 and up, would actually need to be electronically prescribed unless there's some sort of hardship and waiver. Many state rules for that. And then now a federal mandate that you can only get Medicare Part B reimbursement that can happen for one of those controlled substances if it were electronically prescribed, which makes it very difficult for people to prescribe without doing that, because patients often need that reimbursement. One of the loopholes there has always been cash payments, Jonathan, and I'm glad you mentioned that, because there's actually legislation for an EPCS Part 2 that shores that up, that's on the books now and hopefully passes. So a lot of progress on that front. And I would say that largely across most major healthcare systems, especially the larger ones, EPCS is enforced. And so there are some isolated episodes of fraud that can happen. There are some exceptions as you move down into smaller and smaller practices where that can be a hardship. But the adoption of EPCS has certainly been one major contributor to, I think Jonathan said, turning off the spigot of all these inappropriate opioids that have been in the past been prescribed. And so that's one case where there actually is progress on a national basis, on a state basis, in a lot of respects. PDMPs is another one, and many of you are familiar with this, but if you're not, it's the idea that there is this, there are drug monitoring programs and there's better interoperability now. There's still some issues, but in general, for the most part, many of us, at least on the inpatient side, or if you're at a hospital that have access through an EHR to a drug prescribing program, most will connect to a state or another linked up PDMP. And many of them that's incorporated right in the workflow, and you can single sign on right into it, and it makes the workflow easy. And that is the interoperability that we used to crave is actually now required and monitored. And that is one of those things in the dashboards or within the electronic records themselves that is either enforced by reminders and best practices or actually tracked to make sure that all of us, as we prescribe, have checked that database to see if that person has gotten controlled substances anywhere else, even if that is somewhere, in a system across the street and other places. So I think there's actually been a lot of progress in those cases. That was one of the areas we spent the most time on, particularly the PDMPs and the integrations there, because it was very difficult to get those integrations state to state and between systems. But that has actually progressed a lot. It's actually a good example of the power of IT when a group of people who are knowledgeable about that can get together and kind of help the industry work together to support the right standards of interoperability. Would you guys agree with that, Jonathan or Ed or anyone else?
Yeah, the integration of the PDMP into the electronic health record has been a tremendous win, and makes it very easy to do the right thing and allows us to do, like you said, remind people to do the right thing, and in some cases force them to do the right thing.
Yeah. And so, a couple other chapters here, again, some of this sounds like so obvious, but those of you that are out there in the world realize, we were sending people out the door without a lot of patient education. And that's not fair, and it's not right. And obviously it leads to poor results. So actually paying attention to that, actually talking to our patients who knew is very important. And again, you can automate a lot of this. The unique aspect of this particular project and these other work documents and outcomes are, how do you leverage IT to do that, right? So every single time a patient goes out the door and there's a controlled substance, automate a sheet and a routine that actually helps educate and enforce the fact that as you talk that patient through their care plan, you talk through the best practices and what it really means and how you take these things and why and when you shouldn't. And if you can avoid them, you should. And here's why, right? And actually anti-inflammatories can be very effective and exercise can be effective. And here's what you should think about and do. And that makes a big difference. And then, this community outreach and collaboration starts to get at some of the issues that were brought up in the chat and on the discussion around interoperability, not just at the hospital, but that continuum of care as patients leave and go out into the real world, because that's the real challenge, right? If you think it's hard to provide care in a controlled environment in a hospital, when someone goes home back to their environment, which they may not have good resources, and they may speak a different language, and they have a lot of influences around them that are difficult to deal with from a socioeconomic standpoint. And the care that they're getting is few and far between because, we have limited resources and availability out there, particularly for behavioral health and substance use and dual diagnosis. How do you coordinate with some of the resources out there? And truthfully, earlier on, we focused on the top aspects of this playbook because that was where we could do the most good, the fastest. And we wanted to stop the problem that we were creating. Like, first and foremost, we all felt we were guilty of putting too many opioids and other dangerous meds out there in a way that was actually contributing significantly to the problem. And just kind of
I would just add, I think that was the PDMP revelations early in the task force were quite astounding. And I think this is a recurring issue, challenge, barrier, whatever you want to call it, but there are no national standards around PDMPs. And in our most recent work, we've added a number of behavioral CIOs to our task force, and we really didn't know because we come from a mainly hospital focus. We didn't really understand the behavioral and mental health market. We now do. And a lot of it is driven at a county level, let alone a state level, but certainly not a national level. So we have a big hill to climb in terms of developing standards. And, for example, a continuity of care record was established in hospitals years ago, which led to our EMRs and our adoption, and that we have a long way to go in the behavioral space. And PDMPs are a prime example of that. There's been one vendor who owns about 90% of the market, and they make money off having customized PDMPs for regions and states. And when we tried to take that on, we hit the wall. So I think we really have to develop better solutions for common data sharing, like health information exchanges, that various organizations with different levels of EMR capabilities can actually interchange data, because these patients see a lot of providers. People with opioid and substance use disorders um, are going through a lot of treatment, or they're not, and they're shopping for meds in the emergency room or whatever. And we don't really know the patient. So we're actually putting them at risk without knowing basic fundamental data about their history. So I think that's the PDMPs really woke us up on that, and that there wasn't one solution we could do. And so when we all agreed to do electronic prescribing and interfaces to the PDMP, every hospital had to develop a unique solution almost, because every state's different on that level. So, challenges.
And Rachel, your question is a great one in the chat, just asking, if there are defaults or checklists, alerts within the electronic systems to make sure that the right way to prescribe or to treat is being done. And absolutely, there are. In fact, we'll go to the next slide in a minute, but that is absolutely part of the order set maintenance and care pathways. And the whole idea is there should be good best practice alerts and gates where providers are led to do the right thing and stopped from doing the wrong thing, or need to document why they need to do something that's an exception. Because the truth is, oftentimes there are legitimate exceptions, and that's fine. But regardless, yes, that's absolutely core to what this effort was about, and particularly that order set maintenance and care pathways was us trying to make sure that people were sharing and working with their EHR vendors and their e-prescribing vendors and others to say, here is a proven way that you can use a template and an order set care pathway to go through and allow for that kind of the clinical care. And if you want to go to the next slide, that leads us to kind of where we're at today. And as Jonathan and Ed mentioned, look, the opioid epidemic has changed through the years. And this gets to some of the issues brought up in the chat and in the discussion earlier around interoperability with the community and adapting some of the efforts, both from an IT perspective and also clinical and operational, to adjust to the epidemic. And so, many of you are probably familiar with this, and certainly in Ohio, you're at the kind of front end of a lot of this. But early on, we saw a lot of the iatrogenic extra prescriptions going out, and then heroin, and then, of course, fentanyl hit the streets. And suddenly, the alarming overdose rates and death rates went so far up. And, lately, luckily, they've just started to come down. And I know there's potentially multiple reasons for that, some of which are good and some of which might also be worrisome with other co-ingestants and things like that. But I do think that the cultural changes that are underway and education of patients, and then specific things like actually prescribing naloxone, for example, and distributing naloxone and getting it in the community and educating people that, hey, this stuff is so powerful, can kill you in under a minute, and you need to be prepared and use a buddy system. And, there are these things called fentanyl test strips. And, a lot of that you may not think of as informatics, right? Like that's not a computer-driven thing. But the interesting part is, well, it can be if you automate distribution or at least prescription, but hopefully just distribution of naloxone with every opioid prescription. And Jonathan, you want to comment a little? I know you've done a lot of active work on this.
Yeah, so one of the very first interventions we did in the electronic health record was around Narcan. There were good early studies, and there's a lot more now that shows just having Narcan in the community, hanging around in people's houses, saves lives because it's there and people will use it if they're given the opportunity. So we actually initially created an alert in our electronic health record that, if you prescribed an opioid, it would tell you need to prescribe, naloxone with it. And we also encouraged our providers to give out our free kits, which had early on naloxone. Now they include fentanyl test strips and xylazine test strips and all other kinds of important education and things. But yeah, you can use the electronic health record definitely to kind of push people toward doing that. And again, naloxone has been one of the most important interventions we've done and one of our first.
And I think, the other piece that people are getting at is, connecting them to resources in the community. And then, specifically follow-up therapy and buprenorphine, right, for opioid use disorder. Because that is definitely evidence-based. If someone starts that and continues treatment, they're at much decreased risks of morbidity, mortality, and adverse events. And so we absolutely want to try to get this started more. We certainly try to do it sometimes in the ER. It's not always easy to do, and people aren't, it's not always the easiest scenario, but linking them to the right resources in the right way. And that gets at some of the issues that were brought up in the chat around, how can this be done? And there were some regulatory issues Caitlin put in the chat around 42 CFR Part 2, which is a rule basically allowing sharing of information, but due to the stigma and worries, it just a lot of people don't realize how important it is. And John and I, as ER docs, know it. While it's sometimes tempting to say, hey, as a patient, I want to select what people know about me, and this is something that's private and I don't want people to know it, is actually really difficult. And unfortunately, it's a product of the stigma. And Ed said this, if someone has diabetes, well, it's not like we withhold that information. I mean, they need medicines just like someone with addiction has a medical disease and needs medicines and needs to have their healthcare providers understand that. And there's so many implications for an ER doctor when someone comes in unconscious, knowing what medicines are on and knowing what medical illnesses they have can literally be life or death as far as understanding and how to make the proper diagnosis and treatment in enough time to save their life. And only having a little bit of the information is incredibly dangerous. So, we as a task force are looking at how we can help contribute to destigmatizing and making sure that records are shared, that things are transparent, and that people get the care that they deserve and need and the respect that they deserve and need. Not always easy to do, right, John and Ed? And I don't know if Josh is still on, but we have some experts on the task force that have been doing some good work in this.
I know there was a question in the chat about health information exchange and different EHR systems. So Metro has worked with CliniSync. I know a number of the major health systems have worked with CliniSync. The challenges are, especially for some of these smaller providers, if they're using small niche electronic health records, or if they're using some of the cloud vendors, it's very difficult to get that all synced up. And there is a cost for CliniSync, which some practices are not able or willing to afford. That makes it again a challenge. I know that we encourage CliniSync to reach out Clinic Sync is an independent entity. So while we have, we can talk to them, we don't have any control, which is frustrating at times. But yes, both Metro Health and other major health systems in Ohio have brought this to them, and as more and more practices and more health systems are on major EHRs, that should get gradually better. But it's definitely a challenge.
And just talking through the major EHRs, we on the task force looked at 3 of the major EHRs and had them respond to our questions around exactly what they offer, how out of the box it is compared to how much it needs to be customized, how pragmatic and useful it is. So we did that for Epic and Oracle Cerner and Meditech, and they were all great and very cooperative. And I think a lot of progress has been made in at least each of those 3 major vendors. As Jonathan said, there's a whole multitude of electronic systems out there, and I think a lot of them are starting to make improvements. And it's really important for everyone to know what the capabilities are of their own system, and then work with them. And even between vendors like that, we've seen an ability to collaborate and understand and be transparent. Of course, they want to each create the best versions that they can for their own customers. But there is actually a fair bit, like Ed said, of sharing of best practices, and then they can code it in how they want. But in some ways, that has actually helped everyone raise the bar, because some systems might get something with better integration. PDMP was a good example of this, where certain places the workflow was simply like in the record. It was like, hey, Dr. Kelly, you have to check the PDMP and we stop you now. And I'm like, well, thanks. I have to go separately, open it up, find it, remember my password, and log in while I'm trying to, take care of 20 other patients. And people fought back at that. And then they realized maybe the competition had a better version where it linked right in directly to the EHR, and they did the back end homework. And then me as a doctor, I can just click and it automatically opens the PDMP for me. Now I'm going to check it every time. I'm like, wow, that was easy and it was really helpful. And so you'll see those seemingly little IT workflow improvements make all the difference in the world in the heat of the moment when you're prescribing. And so what we did as a task force, we looked at the things we thought were the highest yield for the most people. And then now we continue to work downstream on that to say, okay, now using these best practices, do similar things at these other vendors. And, now that we've gotten through some of the, making sure we have Narcan in the field and buprenorphine, how do we now make sure we're getting that communicated and coordinated with the community more? And so this is where some input from you all is actually helpful in your own region on, what are you looking for in your area? Absolutely, at the Opioid Action Center, you should go and you can look at each one of these chapters and dig into it, see what's helpful. Contact anyone here. If we can help, connect you to any other friends around the area and around the country. And then work with your own partners, your own local constituencies to see if there's, ways this could be improved.
So I'll just add a couple things to that. The first one is back to the collaboration. My experience is if I reach out to a CMIO or a chief clinical officer at another hospital system, they have never told me no about sharing best practices for opioids, sharing tools they've built within their electronic health record. I think sometimes if you go administrator, you get some of that reluctance because that's their baseline default. I think the baseline default of the providers is to share. I would encourage you to, take that route. You talked about the PDMP, Sean, so important. Ohio has certain laws around additional documentation that's required at certain levels of morphine equivalence and so on and so forth. We've baked that into the PDMP. When you open the PDMP, it now gives you the opportunity to document that additional information right there. Makes it super easy to meet your state requirements, and doctors generally like following the law. They don't want to get in trouble there either. But again, it's so much easier for them to do it if it's right there, and they don't have to think about where do I go now, what do I log into. And the last thing I just want to comment on was you mentioned the fact that we polled the vendors about what functionality did they have and how out of the box was it. I can't speak for the other two vendors, but I know at Epic, those discussions were a piece of the push that led them to develop their opioid brain trust. And that's, as an Epic customer, it's been a big resource that I participate in. And I think it really has helped Epic, try and coalesce around this effort so that every user, every organization doesn't have to build their own tools. But I think that them developing that was in part based on CHIME's efforts to, call out what do you have, how much is out of the box, how hard is it for customers, and I think that helped them realize it was hard, and they needed to help make it easier, and they are.
It's a great point. I want to make sure we're addressing any of the questions that came up. And Matt Ramos, you had a great another comment or question just around, do you see any opportunities with employers who offer group health insurance, providing education support for employees and their family members, for example, communicating where to find local resources or how to navigate the health plan? I would love this. I think it's great. Again, my personal connections with the payer side are less. I will send it around the room to see if people have experience. I have started to work with some other vendors, particularly in the telehealth, behavioral health space, where I think is really interesting. And there may be more resources available out there when you start to involve some telehealth visits for follow-up in addition to the in-person visits, just given the capacity issues and, practical issues for these poor people who may not have the means to go 2 hours to get to some follow-up appointment to get seen and evaluated and started on therapy or to keep therapy. So I think, again, this is just another example to me where embracing technology that is being adopted around the world for other reasons, this is a worthy usage of something like televisits, right? And again, there may be aspects of this that are appropriate for that, maybe not. Maybe it integrates with some of the payers and employers, or maybe it's just with the healthcare systems, all yet to be determined. But those are just some thoughts off the top of my head. I don't know if Patty or Jonathan, you know anything about the payer and employer side. I think that's a great angle.
I know there have been startup vendors that have developed products to sell to employers that are education for the employer on addiction, all addiction, and then also tools for the employees to manage workplace stress and other things to hopefully help dissuade them from using any substances to deal with it. I don't know how well they did. The one that I'm thinking of specifically was out of South Carolina, and their initial target audience was the employer, and I think they actually had shifted that and made it more of like a social type of platform for individuals because they weren't getting any traction on the employer side. Also, off of this topic, one thing to add, excuse me, Matt, is from a CIO standpoint, I have experienced the same. If I reach out to another health system CIO about any kind of technology, whether it be the electronic health record or something else, typically it's an open door. And yeah, let's discuss it. Let's share ideas. Let's share, things that we've done that's worked. But if you sit at the executive table and you ask the question, can I do this? The answer is going to be no. You just have to go do it.
Forgiveness, not permission. Matt, you
exactly.
had a question?
So first of all, thank you guys. It's been very, very helpful. I have to drop in a few minutes, so just want to start off with that. And I appreciate your guys' comment there. I think this is probably so I'm on the employer side, obviously, and I probably not the target audience for this group, but it's been very helpful to hear your guys' perspective on all of these different things. I don't hear it. My last question was more on the payer side, and that's the employers are getting kind of everything from the payer side, and it is a very different perspective in terms of how they are describing some of these situations versus what you guys are describing. And I think that's important to understand, but I also think where employers like Eaton are trying to figure out what else can we do, it's we have programs, we have benefits, we have things that we are paying for that we're offering, but then Eaton especially, we have such a diverse population, And really where we can see the effectiveness of those things is in the communities and in local resources, and where they're going to more likely tap into those things. And I think the health plans and the insurance companies and all the technology is great and they're in the right direction. But I think it's probably, some low hanging fruit of just working with employers in the different areas of identifying what those resources are. And especially if there's some high risk populations, I think they'll be very receptive to partnering and figuring out how can you just sort of get that broad education and awareness, so that it's not kind of each party trying to do everything on their own. Because it does sound like we're all trying to strive for the exact same thing, which is improve, member patient health and well-being. And so it just sounds like we're probably maybe doing things in a little bit of a silo. But very, very excited to hear all this stuff, because again, it's fascinating to hear the other side of the landscape. And I have plenty of things that I'm inspired and, ready to ask my insurance companies about in terms of some of these things I'm hearing. So thank you for having me.
Yeah, Matt, thanks for your input. And I don't think you could be any more right about all the really powerful stuff is more likely to be local. And one of the things that we used to do at our hospital was we had just a sheet of paper that was printed out with the local resources and phone numbers for them. And now we try to make as much of that electronic as possible. And that's not something. Some of that's across the whole system, but a lot of it is local. So you need to be cognizant of that and optimize for that, because the truth is, I think Matt's 100% right. Like, we're all not gonna do something. We're less likely to do it if it's some nebulous thing that's national, or we don't really understand it. But if it's your local resource in your neighborhood that you're much more likely to leverage that, I think. I don't know if anyone else has experience with that or recommendations.
I was just going to say, I do a lot of work with the grassroots organizations and a lot of groups that are focused on the health of their micro level, like neighborhoods. And I feel like they're not aware of all of this side of things. And then there's like also a challenge of, how could you possibly know of everything going on in every neighborhood in the community you serve or you work in as a clinician? But I was just thinking to myself, like, what are those bridging resources? So like, could a community health worker or somebody who's like, they're going to be the ones who are more familiar with that space. And at least if you can make that connection, then maybe some of those ongoing supports can happen.
I think that's a great point. Well, I guess I just wanted to make sure.
Sean, I'm sorry, I got to jump off, and I apologize, but I've got another commitment. But this is really encouraging, and I'm eager if we could have a second follow-up conversation. There's been a lot of ideas, I can see the lights going on, and I think there's maybe more opportunity to continue this, and I'd be open to that. So I just thank you for hosting us, and I'm sorry I've got to leave. Sean and Jonathan, thanks so much.
So I think we'll probably end it up in just a minute, but maybe if you could go back to the slide of resources. Yeah, perfect. Just want to emphasize that both of these playbooks are available. You can click on them, go to the chapters, there's interactive content, and then also a lot of different podcasts and other resources that are available there. And a lot of them are, interviews with experts, sharing and going through in depth a lot of the topics we just covered and many more.
And I'll just throw out there that at least in Ohio, part of the PDMP functionality is community resources for therapy. That will help you find somebody who can provide your patient with therapy as an outpatient, if you're not able to do it or your health system doesn't have that resource.
Awesome. Yeah.
Great.
I just want to make sure I gave, if any last questions. I know there's been a lot going on in the chat, and I'm grateful for the time we're taking to get to those questions. Is there anybody who has any final thoughts or questions? You're also welcome to come off mute if that's helpful.
I'd like to comment more on Jody's question about Find Help or Unite Us. Those are, in terms of sort of sourcing all of the community resources and making them available to the clinicians that are trying to get help for their patients. Those are the best tools or at least Unite Us, that's the one I'm familiar with, is the best tool I've ever seen in action. But it's problematic because it's one health system at a time. It's not like a whole community is buying into one of these products and sort of consolidating all the resources. But I do think there's a lot of potential there. And I don't know how we take that potential and expand it out. But I do love at least Unite Us. I'm most familiar with.
Yeah, so Unite Us, and maybe Dr. Sif too, since he's with Metro Health. Metro Health really brought Unite Us to our region, and to my knowledge, we call it Unite Ohio, but Unite Us platform that all the hospitals have the ability to use it. But the problem is that information trickling down to those front desk support staff that are helping the patient. They don't always, so we hosted, the Opioid Consortium hosted a Unite Us forum for hospitals because we found out like the addiction and pain management areas didn't know they even had access to it. So trying to get that information out throughout the health system to the people who are actually using it. And then some people are still using their own Rolodex of people that they commonly refer to. And we also have a very active 211 in our region. And so there's multiple, it's like trying to get everyone on the same page because it's only as good as those referrals coming in and the providers and community-based programs who are answering those calls to the referrals.
Well, and I think the other piece of that is EHR integration. It can't be a separate thing you have to do. Right. And if my Rolex is in my EHR, I won't need that Rolex anymore. Right. But I need a few positive experiences to see that's really going to work. Otherwise, they're going to go to where they know they can get the answer and it's fast. So.
Absolutely. Yeah.
We have a ways to go, but I think it's very promising. I hope you all do too.
Yes. Thank you.
Mm-hmm.
I just want to thank doctors. Caitlin, go ahead.
I just wanted to ask if that educational, if that's a recording that is open to the public, the Unite Us educational piece you were talking about, or was it Find Help?
They did not allow us to record it.
Okay.
So we don't have the recording of that. But it's a good, yeah. And I know Find Help, which is other areas are using Find Help. And I know our payers, a lot of our Medicaid payers use Find Help. I know they just had a Connect to Care Summit the last 2 days, a virtual summit where they were sharing a lot of their resources. I don't know if that's available online as a recording or not.
Yeah.
Thank you.
I know that some folks have had to jump off and we're kind of closing our time, but I just wanted to again thank Dr. Kelly and Dr. Sif and the whole CHIME team that has shown up today to share with us. I've been very impressed with the commitment to transparency and the comments about making the right choice, the easy choice. I think that's so important if we're going to continue to fight this opioid epidemic. And I'm excited about the CHIME toolkit and how we can continue to promote it for the Center for Health Affairs and our partners to utilize. So we look forward to continued conversations. We just have a few quick reminders. So I think some of you may be getting our consortium newsletter, but if you haven't, you can actually scan that QR code and we will continue to post opportunities like these, policy updates, other news and research related to opioid epidemic and how we can all continue this fight together. That's a monthly chronicle that goes out. We also put trainings in there that as they are available. And if anybody ever has content that they want us to share as well, we are happy to take those submissions and promote it to our network. In addition, the Center for Health Affairs has the Connect NEO event next week. So this is our annual meeting and there's still time to get tickets. It'll be held downtown Cleveland, and it's going to be a great opportunity to network and to also hear from similar topics or other issues that are going on in our healthcare system. So we hope you'll take a moment to join us. We talked a lot about chronic pain today. But we recently put out our report this past April. We did a series of focus groups back in the fall, looking at the lived experiences of people who use opioids to manage chronic pain, which was a great primer to today's conversation because a lot of the issues that were identified by our participants we've been able to discuss here today. But we really looked at what's working well and what the opportunities to grow are. And we are going to be hosting a session in July to further expand that conversation and look at how we can advocate for this population. So save the date. We don't have the registration out, but July 17th, 8:30 to 11, we're actually hosting an in-person session / roundtable looking at the future of pain management, looking at non-opioid pharmacological options, looking at having a panel discussion with some of the people who are affected by this and those who might have some solutions. So we hope you'll join us and we'll continue to share information as details are confirmed. I think that is it for today. So thank you so much again for your time, for being here, and I'm excited about the continued collaboration.
Absolutely. Any last feedback, questions for anyone? Anyone with questions about the opioid consortium at all?
And if you can fill out the evaluation, I think Jody shared it once already.
Yeah, I'll
but
share it again here.
It
There's
is
a
helpful
survey.
for our grant purposes. We do like to get feedback on these sessions and improve future offerings.
So our opioid consortium education series is supported through an OD2A local grant, which is a CDC grant to Cuyahoga County Board of Health. And there's about 13 other grantees under this grant that we partner with, but we're very grateful for that funding. We don't know the future of the funding. So I think everybody's, whenever you say you're funded by the government these days, there's a lot of question marks related to that. But we are so happy to be partnering with them and providing these education webinars. We've been doing them every other month. And so we hope we can continue that work as well. And yes, I'm just very grateful for the CHIME team. This has been very informative and enlightening, and I hope it is just the beginning to ongoing communication and partnership.